Hi, my name is Sierra. I'm here with All Things Aesthetics. Today we have esteemed plastic and reconstruction surgeon, Dr. Alex Mesbahi. He is based in the Washington, D.C. area and also treats patients in Beverly Hills. We are super excited to highlight a lot surrounding breast augmentation and rhinoplasty. And Dr. Mesbahi, I'll have you introduce yourself.
Thanks. I'm Alex Mesbahi. I'm a board-certified plastic surgeon here in the DC area, and also, as Sierra said, go to Beverly Hills. My training is in cosmetic surgery and also in microvascular surgery, in which we treat a lot of breast cancer patients as well. Part of the National Center for Plastic Surgery.
Wonderful. All right, let's dive in. So would love to just know what got you started in the world of aesthetics and how you chose plastic surgery as your specialty.
Well, I was fortunate because I came from a medical family. My dad's a surgeon, my mom is an OBGYN, my sister's an ER doctor. So I guess it was in a way in my genetics, but I was definitely oriented towards surgery. What I loved about plastic surgery is that it's one of the few specialties which operates from head to toe. It's also a specialty that other specialties call upon, whether it's for wound healing or for other areas of expertise. I think the other thing that I really love about plastic surgery is that there's so many ways to do a given procedure. Take an appendix out, there's basically one way, but there's so many ways to do a rhinoplasty or different options to do a breast augmentation.
And I'm excited to dive into those things. Wonderful. So I know, you focus primarily on rhinoplasty and breast augmentation, and as you mentioned, breast reconstruction as well. So let's just kind of dive in. Rhinoplasty, I know it's a procedure that a lot of patients are very interested in. What is your approach and your technique to rhinoplasty cases?
I think the most important thing with rhinoplasty, it's not kind of a one nose fits all. So there's a lot of examination of the face, a lot of functional things that we need to look at. Is there breathing? Are there structural abnormalities internally? So we always take those into account before approaching that.
Wonderful. So as you're assessing facial symmetry, obviously the nose is the forefront of the face. So how do you assess a face to determine, that one size fits all, which is obviously not the case. So how do you figure out, what the best just overall aesthetic is for each patient?
There's a lot of scientific ways of doing that. There's rule of fifths and rule of thirds that are in all the textbooks. But I think the most important thing is you just have to have an aesthetic eye for it. Sometimes it's different culturally. There's so many beautiful rhinoplasties that are done in Turkey, but those noses tend to be very prominent, sometimes very straight, and that doesn't always appeal to people in the USA, for example. So I think just kind of having the right idea of what your patient is looking for and kind of the aesthetic eye is probably more important than any kind of exact rule.
Understood. Awesome. So in terms of rhinoplasty, do you find that you also have to do any other types of facial balancing in conjunction with that surgery?
Probably the most common procedure we do with rhinoplasty is chin augmentation.
Okay.
It's really common sometimes for patients to have a prominent nose and a chin that's a bit retruded. So we treat that sometimes most simple ways with fillers or chin augmentation with an implant.
And then are there any instances where a patient would not be a candidate for rhinoplasty?
There's no real physical reason why you wouldn't be a candidate for rhinoplasty. There's probably some medical reasons. If someone has bleeding or clotting irregularities or other reasons why they wouldn't be cleared medically. And then probably in the rhinoplasty world, one of the most important reasons would be actually psychiatric. A lot of issues with body deformity. And there are certain subset of patients sometimes that even if you kind of hit a home run, will still never be happy with rhinoplasty. Those are the patients that sometimes can be challenging to identify.
Understood. So in those instances, do you recommend psychiatric evaluation or support, or how would you handle those?
Yeah, I think we all are trained to identify certain red flags, and if we see those, then that's something that we would recommend.
Okay, wonderful. And I know a lot of patients get very nervous when they hear that maybe a bone has to be broken, or it's a more complex procedure. So can you debunk the fear around just the pain that people think of when it comes to breaking a nose to achieve their ultimate aesthetic?
Yeah, it's quite different in the face.
Yeah.
Really, I think there's minimal pain associated with the rhinoplasty.
Right.
Especially when it's done delicately. I'd say most of my patients are off of pain medications by the first couple of days.
Okay.
Of course, there's a lot of swelling. People feel like they're congested or like their nose is constantly running. That's probably the most common complaint after rhinoplasty, but the part where we have to fracture or shave down the nasal bone doesn't really seem to be very debilitating.
And I oftentimes see, as you mentioned, patients not necessarily being happy with their initial results. So maybe they went to a physician that, didn't give them the results that they were looking for. So I know secondary rhinoplasties can get complex. So can you talk about just the importance of seeing a board-certified plastic surgeon, for these procedures?
Yeah, I'd say a board-certified plastic surgeon or board-certified facial plastic surgeon is really important. I'm always amazed by sometimes patients come in and they'll put more energy and effort into researching a car than the person that's going to operate on their face or body. So really important to kind of see someone with some experience that can show you a lot of before and after pictures, and that really kind of specializes in a certain procedure and doesn't just kind of dabble in it.
Correct. And you're recognized by the American Society of Plastic Surgeons. So I know that there's a lot of conversation surrounding cosmetic surgeons versus plastic surgeons. Can you talk about the difference and what a patient should look for when they're qualifying their plastic surgeon?
Right. So there's really, I think, only 23 specialties that are recognized by the American Board of Medical Specialties. In the plastic surgery world, that's really only the American Board of Plastic Surgery and the American Board of Facial Plastic Surgery. There is something called the American Board of Cosmetic Surgery, but that's not a recognized board by the American Board of Medical Specialties. What that means is there could be an internist, there could be a gynecologist or radiologist, anyone really with a medical license that can take a course and actually start doing things like liposuction or breast augmentation. So seeing the term board-certified cosmetic surgeon or someone that only says that they're cosmetic surgeons
should yield some extra research.
Yield some extra research. Doesn't mean that they're bad doctors or bad providers, but it may mean that their training isn't quite the same as us.
Yes. Okay. And how would you say that their training differs? I know you mentioned just a course. So what did your training and your
So I did 6 years of plastic surgery training, and I did an additional year of a microvascular surgery fellowship. So before I even started practicing, I did 7 years of training just dedicated to plastic surgery. There can be someone who did a 3-year internal medicine residency or didn't even finish residency, but they have a medical license, which typically you only kind of need to finish your internship year to do that. That can call themselves a cosmetic surgeon and do liposuction or really any other type of plastic surgery procedure.
Right. Okay. And I know that you do a lot of training. You go above and beyond, and you're often featured by a lot of different boards to come and have conversations with your colleagues and peers. So commend you for that, always staying ahead of the curve as far as your learning goes. And then in terms of rhinoplasty recovery, what does that look like for patients? I know you mentioned pain meds for a few days. Would love for you to dive into that.
Every patient's a little bit different. Some patients come in and they look like nothing was done, and I've also had patients come in. I did essentially the same type of approach, who come in with a lot of bruising and a lot of swelling. So there's really no format. I think there's certain trends that are happening in rhinoplasty right now. For example, one of them is called preservation rhinoplasty, in which I went to Istanbul to learn. And so there's a lot less trauma that happens during the rhinoplasty, and I think that kind of helps speed up the recovery.
Awesome. Let's shift gears and we can talk about breast augmentation. I know it is one of the procedures I've seen your before and afters. They are impeccable. So let's talk about the different types of implants. I know a lot of patients are kind of trying to get away from implants. So let's also discuss fat grafting. How do you go about deciding which is best for each patient? And can you kind of talk through what each of those options look like?
Sure. So as far as the implants go, there's saline implants, of course, and then there's silicone implants. What a lot of people don't realize is that the shell of all of those implants are exactly the same. So what's kind of making contact with the body is still a silicone surface. There's different types of silicones. There's all kinds of what we call cohesivity, which determines kind of the rigidity or the firmness of the implant. There's different surfaces as well. And the most recent important issue as far as silicone implants go is kind of the surface. So textured implants, for example, have been associated with something called ALCL, which is a very rare lymphoma or cancer of the immune system. So when my patients come in, we go through them. They actually get to hold the implants and see what I'm talking about. But it's probably been about 10 years since I've used a textured implant for that reason.
Are those still in production? Or?
Yeah, they're still available with certain companies in the U.S. They're more broadly used overseas.
Okay.
As far as fat transfer goes, it's a very reasonable option. There's certain things that people need to know. One is about 50% of that fat typically will get reabsorbed. So you may need additional surgeries to kind of get the look or volume that you want. Also, sometimes if the fat doesn't get reabsorbed and it stays around, it can form kind of a hardened area called fat necrosis. Sometimes you can feel that, and if it doesn't go away, that can kind of prompt a little bit of concern because now there's potentially a lump in the breast which we need to get worked up.
Okay. And then in terms of breast implant placement, I know there's above the muscle and below the muscle. Can you talk through that and which one you recommend in which case?
Yeah, so there's above the muscle, as you said. Sometimes people call that a subglandular. There's another layer above the muscle, which is called a subfascial augmentation, which just kind of creates a little bit of separation between the breast gland and the implant. So for patients that are really active, for example, they might be trainers or bodybuilders, sometimes that is a more reasonable option. Probably the most common approach is called a dual plane approach, which is you still go still go below the muscle, but there's kind of a portion which covers the implant, and then there's a portion below the breast gland.
Okay, right. Cool. Awesome. And then incision sites. So we talked above and below. So where is the incision site placed? And, just visibility of those scars following surgery. I know there's additional treatments and lasers and such that you offer here.
Yeah.
Let's talk through the
So the three most common approaches would either be transaxillary, which is through the underarm, periareolar, just going through the area below the nipple, and then through the breast fold. There's, pluses and minuses to each approach. Going through the underarm is a nice approach because there's no scar on the breast. But I'll often tell my patients, especially if it's below the muscle, that the approach that's taken to the breast is really never closed off. So look great for a couple years, but over time, because of the force down on the implant from the muscle, they often tend to kind of go back out toward where they kind of came from. And that can kind of create a very unusual look, sometimes a very wide gap in the cleavage area. So it's not my favorite approach. Through the areola is also a reasonable approach. There's a risk of what's called capsular contracture, which is probably a little bit higher going that way. And what that is basically the tightening of the scar tissue or the capsule, which can form around the implant. That could mean revision surgeries in the future.
And how does that impact breastfeeding for patients who are looking to have children in the future?
The safest way is probably going from the breast fold, in my opinion, because you're not violating the breast gland at all, especially if you're going below the muscle. You're not around the nipple, so you're not kind of injuring any of the ducts or the tissue that kind of connect to the nipple. So you can still breastfeed even if you have an incision through the areola, but probably the least complicated way for someone who definitely wants to breastfeed would be to avoid the nipple.
Okay, wonderful. And then in terms of the scarring after, I know it's hidden underneath the fold, but how would you address scarring if there was a visible scar that a patient wanted to have concealed?
All scars are visible. They never go away. So we try to make them as short as possible. If it's placed correctly, then really it just hides right in the breast fold. So we do start a medical grade scar treatment, usually a week or so after surgery, and we'll have our patients treat for 3 months. If there's any poor scars that form for some reason, which would be unusual, we can treat it with steroid injections, for example, and also lasers, which we have in the office.
Wonderful. And then in terms of implant profile, I know it's by preference, but how do you guide your patients through determining what implant they should get? High profile, mid-size, so on and so forth.
Yeah, it always kind of comes back to, hearing what the patient wants. I know stories of really prominent plastic surgeons who will just say, bring me a picture, and they'll kind of base it all on that. So we do really specific measurements in the clinical exam. I also use something called Vectra 3D imaging, which is a really nice way for patients to get an idea of what different size implants look. So we can actually show them what a low profile would look like and what a high profile would look like. Now, it's never exact, but at least it gives them a sense.
Yeah, and I just want to dive into Vectra a little bit because I know it's exciting to see, okay, this is how I'll look after surgery. So can you talk about that process? I know it's a scan of the body, and then you go in as a surgeon and input, no pun intended, input the measurements and go from there. So can you talk about how that process works so that the patient can understand?
I use it a lot for rhinoplasty and also for breast morphing. Again, you can kind of pick and choose a certain aesthetic based on what your patient is telling you. And then we actually sit down together and go through it. And so we have an ability, if it's the nose, they can tell me it's a little too short or it's a little too long. And then for the implants, at least I can identify a range of implants sizes that they like. We also actually have implant sizers that they can try on in the office just also to see how it looks like with a shirt on, for example.
Yeah. So full transparency, making sure you're on the same page with the patient from
Right.
the start is key.
You got it.
Wonderful. And then breast augmentation recovery. Let's talk through that.
Yeah, so in our practice, typically we'll allow patients to kind of start exercising around the 3 to 4 week mark.
Okay.
There's actually been some studies that show that even after a week, it's safe for patients to exercise.
Okay.
But typically, we at least more commonly will do like a 3 to 4 week time range.
And because you want to reduce fluid accumulation around the
Yeah, the
implants and
potential
such.
for bleeding or fluid accumulation, inflammation. And then also swimming is another thing. So, I allow my patients to shower the next day.
Okay.
But as far as being submerged underwater like a tub or a pool, we usually wait for about a month.
Understood. Okay. Okay. And then they have to wear a specific bra, garment. What does that look like?
Yeah, just supportive bra.
Okay.
Nothing really fancy
Got it.
is necessary. So
Okay.
we just like a supportive bra like up until the 1 month mark or so.
Okay.
And then that's kind of when they get to go buy new bras.
Perfect. And so it does take a little bit of time for the implant to settle in. So you do recommend waiting at least a month to purchase new bras to fit their
I
fluid
think that
improve?
kind of initial swelling
Yeah.
is really probably the first few weeks.
Okay.
So that's why I usually suggest waiting about a month to get a good sense. But there's really several more months of healing that happen after that for the implants to settle.
Perfect. And I know ptosis is a word that patients hear and may not really know what it means.
Right.
So how would you define ptosis, and how would you talk a patient through the need for a breast lift or a standard breast augmentation?
Yeah, so the common word for ptosis would be drooping.
Yes.
So that can actually apply to an eyelid. You see kind of a lazy eye, for example. We consider that ptosis, and it also applies to the breast. So when we approach that, we kind of look at where the nipple is in relative position to the breast fold. And based on that, there's different types of incision patterns that can determine what type of lift is necessary. If the patient wants more volume, typically we'll either add fat or an implant at the same time.
Right, right. And what would the incision look like for that type of procedure?
So there's different types. So
Okay.
it can be a really simple one if there's not a significant lift that's necessary, which is kind of like a crescent, and that will just fall along the border of the areola. It may be like a donut, a circle type of scar, which is prone to certain complications like widening and I think often require revisions. And then there's also like a lollipop or an anchor scar.
Okay. Okay. Awesome. And then I just want to highlight, I know Breast Cancer Awareness Month is coming up, and you have been a leader in a lot of very innovative procedures surrounding breast cancer. So I would just love to just kind of talk through that. As women are getting implants, as they're getting fat grafts, they need to be aware of, complications that could arise, and not to say breast cancer comes from those things.
Right.
But, just making sure that patients are aware of their breast health and how you've made strides in that space.
Yeah, our practice, my partners and myself, we're nationally recognized practice in breast cancer reconstruction, and kind of pride ourselves on that. As much as we love doing cosmetic surgery, it's kind of really the foundation of our practice, and I think it's important to kind of do something that's meaningful in that way as well. Kind of a lot of different things that we do to kind of maintain our abilities, and also kind of develop and offer new methods. So the most recent one would be something called resensation.
Yes.
And basically, with mastectomies, it's not uncommon for there to be near total numbness of the chest. What that can mean for a patient, just even from a protective standpoint, is I've had patients fall asleep with heating pads, for example, or hot water bottles, and develop really severe burns on the breast. So what we're doing now is preserving the sensory nerves to the breast during the mastectomy, and actually using a human donor nerve graft to connect those nerves to the nipple or to the skin. And the hope would be, even though the data is still kind of being accumulated, that at least we can get, very close to a normal sensation in the future.
And correct me if I'm wrong, you were one of the first physicians in the DC area to successfully perform that procedure.
Yeah, that's right.
Yes, congratulations on
Thank
that.
you.
Wonderful. Thank you for tuning in. You can find Dr. Alex Mesbahi at National Center for Plastic Surgery. For more information, like, subscribe, and follow, and visit allthingsaesthetics.com.